So the next speaker would be, we have interest from زي العابدين. Okay. Okay.
Yes, we call Professor M Roach. We're going to talk about what unusual cases have taught me about managing clinically localized prostate cancer and the implication.
Well, thank you very much for this invitation. It's my second time to Morocco, but my first time to this beautiful city. And I'm honored to be able to be involved in this program. All right, okay. So the problem is that there are a limited number of randomized trials that we can base recommendations on. There's great heterogeneity in terms of, even when we talk about high-risk patients, there's different reasons that people are high risk. And then there are a limited number of interventions, whether we're talking about the dose of radiation, the volume, the drugs that we use. But there are many cases that are unusual cases, and we can learn from those and apply them as we go forward in managing patients that come in the door. So I'm going to share with you some cases that I have many cases, having been at the same place for 35 years. And in the interest of time, I won't dwell on this, but I like to talk about the art of radiotherapy, which is based on experience, time, and as you younger people in the audience come to experience this, you'll learn things, you'll retain things, and hopefully pass on the lessons learned and particularly the mistakes that you've made. So I've picked out some examples. So these are all real cases that I have followed for many years. This particular patient was 61 years of age, and back in those days, we treated Gleason 3+3s aggressively. This patient was entered on a randomized trial called RTOG 0126. So this is a study of 79 gray versus 70 gray. And so this is now 23 years ago. So he was treated with radiotherapy just to the prostate, to 79 gray. And one of the things that we noticed is that his PSA nadir, which is the lowest value that he ever got, was 0.92. There was no hormone therapy involved, which is actually on average when you give somebody 79 gray, the PSA should be around 0.4. Typically, okay? But he continued to be followed, and eventually his PSA went up a little bit, so we biopsied him, we did MRIs, and his PSA kept going up. We didn't have PSMA PET at the time, but we did other imaging, and eventually, again, his PSA is going up. We did a CT scan, which showed that he had a 1.1 centimeter nodule that was enlarging superior to his seminal vesicles, possibly a node. And we had that lesion biopsied, and it indeed was a Gleason 4+4. So this is the only evidence of the disease that we had. But the other thing that we noticed was that these are two scans, similar slice, which suggested that not only did he have this nodule, but that the nodule was mobile. That is, when he breathed, with respiration, the nodule went up and down. So I had my urologist implant the nodule with a gold marker, and we proceeded to give him hormone therapy, treat his pelvic lymph nodes, and we did a boost using stereotactic body radiotherapy, 650 times 4, a very high dose. Gave him 2 years of hormone therapy, and he stopped the hormone therapy, his testosterone recovered, and his PSA has stayed down, and actually I have seen him more recently, but the fact of the matter is that this is an example of how a patient can be, even though he has relapsed in his nodes, biopsy proven with a high-grade tumor, that he can be rendered disease-free. And so the first lesson I learned from this patient is follow your patients, particularly if those patients have a suboptimal response to radiotherapy, and also the importance of using image guidance if you have a node which is in an area that's mobile. Most nodes are not terribly mobile. They sit around the major vessels and stay right in place, so you don't have to worry about that. But if they have in certain parts of their anatomy, you want to make sure that it doesn't move so that you can boost that. And this gentleman is a very happy long-term survivor who appears to be cured. And the quote from my department chair at the time is, "If you don't treat for cure, you won't cure those you treat." The second case is a 55-year-old African-American male with Gleason 4+4, seminal vesicle involvement, and bulky lymph node involvement. He looked like he had lymphoma. He had a pre-treatment PSA of 3,900. So most people would say, "Oh man, you're wasting your time, don't. And I had a quiz question, but again, in the interest of time, we got started late. Which of these things would you do? Would you doublets and triplets? Would you radiate them at all? These are all things that we would think about in this case. This patient actually originally went to Seattle. This is back in the days where brachytherapy was really popular. So he went to Seattle and wanted to talk about brachytherapy. And one of the urologists, very famous for doing brachytherapy, said, "Oh no, you're not a candidate for brachytherapy. Go back to San Francisco, see Dr. Roach." So we gave him hormone therapy, and we treated his periaortic nodes and prostate area nodes to 60 gray. We boosted his prostate to 72 gray, and this patient was treated about 25 years ago. So this was after this first area up here. This is after he had already been on some hormone therapy. He was having a nice response to where the yellow arrow is. He was having a nice response in his bulky nodes, but it was still persistent. And we followed him over a number of years after he was on hormone therapy. His PSA continued to decline. He stayed on hormone therapy and has been disease-free for 23 years. I stopped his hormone therapy, and I follow him less frequently now. I'm not sure what his testosterone has really done, but if somebody had told me when I first saw him that a man who walks in with periaortic nodes, bilateral seminal vesicle involvement, Gleason 4+4, would be alive and disease-free 23 years later, I would not have expected it. But he's done very well. And one of the lessons I learned, this is from a paper that we wrote looking at the impact of ultra-high PSA levels on biochemical failure and clinical outcome. And this is one of the problems with the current NCCN risk group system, where you're high risk because you have a PSA over 20. So this is looking at patients that have PSAs. The curves are PSA over 50 versus PSA under 50 in patients with prostate cancer treated on trials. And the bottom line is that although PSA over 50 did predict for outcome a bit, it was not as impactful as Gleason score and T-stage. So the take-home lesson was that PSA is overrated as a prognostic factor, that there appears to be a nodal phenotype of prostate cancer where lymph node, this patient never had bone mets, so this was all disease in his prostate and his nodes, highly responsive to hormone therapy and radiation, and if you don't treat for cure, you won't cure those you treat. The third case is a 67-year-old man who presented with seminal vesicle involvement, Gleason 9, and his PSA was only 1.6. He had, again, diffuse disease. He also had some sarcomatous differentiation in the tumor, and his imaging was otherwise negative for metastatic disease. He did have some reduction in his prostate size with hormone therapy, but despite hormone therapy, he became obstructed. He had diffuse involvement throughout his prostate, and he required an indwelling Foley catheter. And I'll digress for a minute to talk about a paper that looked at what is the prognostic significance of a pre-treatment, a very low PSA in patients who present with high-grade disease. And this study suggests that patients who had low PSAs actually had a worse prognosis. So when you think about PSA as a biomarker, and I'll talk more about PSA as a biomarker tomorrow, it's not as simple as a higher value means more aggressive disease. Having a low PSA in the setting of high-grade disease can actually be a bad thing. So we treated him with hormones and radiation. In this case, I did something that I call a reverse CK boost, where I'm using a stereotactic body technique where we treat the prostate first, 950 times 2. So I tell my patients it's sort of analogous to boxing, where you come out in the boxing ring. Those of you who are boxing fans, Mike Tyson used to come out in the first round and try to knock your head off. I say I like to go out and hit the prostate really hard for these patients who are obstructed. So he got 950 times 2 and then whole pelvic radiation and continued on hormone therapy for supposed to be a couple of years. He had a nice response. His PSA went down. He became unobstructed. And we subsequently wanted to work him up because I was convinced that he was going to have persistent disease. So we biopsied his prostate now some years after his initial treatment. And he did have a focus of Gleason 4+4 in the prostate, seen on MRI, but it was called cancer with treatment effect. Now the literature generally says that if you, after radiotherapy, if you see cancer with treatment effect, that is considered to be a negative biopsy. So we considered that at the time to be a negative biopsy. But the patient was tired of taking hormone therapy, so he stopped hormone therapy. He was lethargic. He said he had belly fat. His libido and so forth were bad. And so he started taking testosterone gel to get his testosterone up to a normal range. And he improved symptomatically and was very happy now 10 years out with a very low PSA. And now age 76. Well, subsequently, his obstructive symptoms returned, and his PSA rose up to 0.217. Now, remember, his initial PSA was only 1.6 to start out with, and now with PSMA PET, we saw a hot spot in that area that correlated with a positive biopsy with treatment effect. And so we subsequently reirradiated that particular part of his gland using stereotactic body radiotherapy, and he tolerated the treatment well. Unfortunately, which I don't have the slide of this, he had progression in his chest with a metastatic focus. And I think from this particular patient, I think that the conclusion that cancer with treatment effect is always evidence that the disease is controlled has to be suspect. And so if you see a very high-risk patient who has very high-volume disease and you do a biopsy, you need to be a little bit more cautious about accepting that as disease control, because I believe that subsequently he had progression locally and subsequently developed a lung metastasis, which has been very difficult to manage. So long follow-up is needed, and if you don't treat for cure, you won't cure those you treat. We subsequently published this as a small series, one of my residents, where we had 3 patients who presented with obstruction. This was for a meeting on palliative care. All 3 of these patients had high-grade tumors, locally advanced disease, and came with catheters. And the bottom line is that we were able to get all of them catheter-free within either immediately or within 4 weeks of completing treatment, and with no significant increase in toxicity. These are the characteristics of the patients, and they did very well. So I've learned that in my experience before, and this is why following patients for a long time is important, is that I never saw patients become catheter-free so quickly as giving them a high dose of radiation up front at the beginning of their treatment. One patient who presented after these cases is my fourth case. This is a 75-year-old man with a PSA of 20 who presented with a prostate of 900 cc's. So this is the biggest prostate I have ever radiated. When I treated him, I was fearful of the potential complications of a 900 cc prostate, and he had tried hormone therapy. It did not sufficiently shrink the tumor, and so we used a very, very tight margin and radiated this 900 cc prostate with stereotactic body radiotherapy. Now, most of you probably would not have radiated this patient. You could have given him a palliative course, and actually the course I gave him was somewhat palliative, but aggressive. So he received this treatment to the prostate, and his prostate shrank from 900 cc's down to, it shrunk by 90% with radiation and hormone therapy. And mostly this is radiation alone. But it was very tight, the margin that I used. And so he subsequently had progression where he progressed mostly outside the field into the rectal wall and into the bladder. And so he represented, and he had worsening urinary symptoms. He also became catheter-free with this radiation. And so we decided that we would re-irradiate him. And this is actually what his radiation field looked like. This time he relapsed in pelvic nodes. Before, he had no evidence of pelvic nodal involvement. So we treated not only the re-irradiated part of his prostate and part of the rectum and part of in the nodes. But in addition to that, we did genetic testing that suggested that he had microsatellite instability. And with a couple of cycles of Keytruda, pembrolizumab, plus the radiation, he had a dramatic decline and actually had a complete remission, not only in terms of the tumor shrinking, but in terms of what his PSA did. Now, subsequently, I have learned he did have some complications, late complications from the radiation, which, of course, we would have done differently had we known that he had microsatellite instability. So the take-home lessons are that, number one, tumor size per se can be overrated, that you should look at these unusual patients with high volume disease to look for genetic markers before you radiate them, and that with aggressive hormones, chemo, radiation, you can treat these patients, and the key is not to undertreat them. Don't assume that these patients cannot be treated effectively by doing palliative treatment that will complicate your subsequent management. So again, if you don't treat for cure, you won't cure those you treat. Had I known he had microsatellite instability from the beginning, and had I known that a 900 cc course of treatment would not necessarily be palliative, I would have treated him more comprehensively, including his pelvic lymph nodes from the beginning, and not be pushed into a place where I was re-irradiating someone who had already had high-dose radiation. Patient number 5 is a more recent patient. This is a patient that is actually a medical oncologist. And this medical oncologist presented to me with NCCN high-risk disease. He was called to have a Gleason 4+4, and he was getting my opinion about radiotherapy. Now, for those of you that follow NCCN guidelines would say this patient should get two years of hormone therapy. Some people would say you need to treat the pelvic lymph nodes and so forth. But we did an MRI which showed that he had a large prostate. His PSA was only moderately elevated. And the fact is his pathology showed a focus of grade 4, which became a Gleason 4+4, and the rest of it showed group 3. And so the question is, how should you manage a patient that has all patients, should all Gleason 8s, 4+4s, get comprehensive long-term hormone therapy with the radiation? And this is what his PET looked like. It wasn't high volume disease on PET. And the decisions to manage him were informed by an interesting study from I think this was from Wayne State, Maha, and this is a series where they looked at patients who presented with Gleason 4+4 as a focal area, and they wanted to look at what was the relationship between a small focus of 4+4, were there parameters that would allow you to predict which patients would actually have lower grade disease at the time of prostatectomy. So what they did is they looked at a cohort of men who had no pattern 5, and they only had a limited amount of 4+4. So they had 105 men, and they found that having less than 2 cores of Gleason 8, this 4+4, with less than 50% maximum tumor involvement of any core for Gleason 8, the presence of pattern 3 in other areas throughout the biopsy specimen, and they were able to combine these various parameters in order to determine which patients were likely to have a lower grade lesion. And in their analysis, they were able to determine the subsets of patients in whom you could come up with an 82% probability of downgrading at the time of prostatectomy. So this shows the probability of downgrading at the time of prostatectomy. And so this particular physician, who I've known for years as medical oncologist, with some informed discussion about his management, we decided to treat him with radiation and a very short-term hormone therapy, treat him as an intermediate risk patient. And with short follow-up, he's doing very well. His testosterone is normal. His PSA is 0.1. He got radiation to his prostate only. So, so that is the lesson learned, that these patients, that there are patients for whom you don't want to follow NCCN guidelines. This next patient was treated in 2013, 55-year-old gentleman, presented with a PSA of 31. He had positive nodes. He had a Gleason of 4+5, and he was treated with hormones and radiation until 2015. After he had recovery of testosterone, his PSA rose to 3.2. We did a PSMA PET, which showed METs at C3, C4, and a rib MET, and he was started on hormone therapy alone, and we did stereotactic body radiotherapy, 800 times 2 to each of the areas that were positive on PET. He subsequently represented with metastases to the calivarium and some other areas. He was treated with drugs alone, with abiraterone, hormone therapy. His PSA declined, and he went on an ADT treatment break. And he did well subsequently. His PSA slowly rose. And then in 2023, had a PET that suggested that he had scattered foci. He went back on the drugs that had worked before, and his PSA was very low. He did well again. He went on a hormone therapy break, and then in August of 2024, developed multifocal uptake, and subsequently had a PSMA PET that showed disease at T7 as the only area that was active, and hormone therapy was started again, and we treated just the lesion at T7 that was lighting up on PET. He received 600 times 5 to the entire vertebral body and 400 times 5 to the remaining body, and has had an excellent response, tolerated treatment well, and is doing fine. So this patient is an example of somebody who presented with metastatic disease. Now he's out 13 years. Currently, he is doing well and is happy, and These patients are, you will see them increasingly with the use of PSMA PET, and the bottom line is they should be treated aggressively. This case is actually two cases. So these are brothers. The gentleman on the left is my patient. He's actually a very famous musician. And he and his brother were diagnosed with prostate cancer at almost the same time. His brother lived on the East Coast. He lived on the West Coast. He was treated during the time that we were running our trial, RTOG 0924. And so the trial was designed, it opened in 2011. So by the time I saw him in 2014, his PSA was 39. He had ECE, then it was up to 50. He had 11 of 16 cores positive with probable ECE. He was seen in 15 by me, and he completed whole pelvic radiation. He received a high dose rate brachytherapy boost. And around the same time, his brother had a PSA of 47.6, which went up to 77.8. And the problem is his brother was never treated for localized disease. So what I've got here is the follow-up on that. So subsequently, his brother died of prostate cancer now 19 years after diagnosis, while the patient who I treated continues to perform music, is no evidence of disease, has a very good quality of life, is still sexually active, and so forth. But the bottom line here is the long natural history of prostate cancer, and one of the reasons it's difficult for us to show the benefits of treatment in patients who have prostate cancer, because you have one brother who is treated, one brother who's not treated, and yet it took a very long time to see a difference in survival. And this pattern of death from prostate cancer in people that present with localized disease is actually quite typical. This is from a series from Hopkins looking at predicting the cancer-specific survival at 15 years. And the bottom line is that of the men who die of prostate cancer, 80% of them die between year 10 and year 20, which is exactly what happened for my patient and his brother. So my conclusions are data from phase 3 randomized trials should drive our management of people with localized prostate cancer, but there are a number of limitations that these trials present. First of all, there's a limited number of trials, there's heterogeneity, there's limited eligibility, and there's only a few things we can do. But unusual cases can sometimes teach us about the limitations of interventions and help us identify patients who might benefit from very aggressive treatment. We should include biomarkers. We should make sure they don't have microsatellite instability. We should not write a patient off because they have a very large tumor or very high PSAs. And we have to remember that this long natural history is something that will make it difficult for some of us to prove that patients benefit, but it's important that if we treat these patients, treating for cure is a very important philosophy. Thank you for your attention.
Thank you. Thank you very much for this wonderful talk and inspiring cases.
I don't know if we have time for questions. I know we started very late. If there are questions?
I'm sure that we will have a question.
2 questions?
Yes.
Okay. In English, preferably.
We can translate.
It's 9,900.
No, it's 3,900.
No, I mean the
The
size
900 cc
the size of the
prostate, yeah.
prostate.
Right, yeah.
Did you irradiate the whole prostate, or just you keep some margin?
I radiated pretty much the whole prostate. The dose was modified, but I radiated the whole prostate.
There was no side effect from
Well, there was side effects, and that's part of the take-home message is that if I had to do it again, understanding what I understand now, First of all, if you see a patient who presents with a 900 cc prostate, you should think about things like microsatellite instability and understand that these tumors may be inherently more responsive to drugs and radiation. And that probably I would have given him pembrolizumab for a while and then radiated his prostate and his pelvic lymph nodes. At the time, it was semi-palliative, and the patient has lived longer than I expected him to live. And when you have a patient that you've treated aggressively like this, you can get some complications related to that. He's still alive, but he's had some post-radiation complications.
And you say that hormonal therapy didn't work for him for downsizing.
It downsized him a little bit, but he was still obstructed. He didn't become unobstructed until I radiated him. And then he had progression, and then we got the biomarkers. The ideal way to manage a patient like this, and the information wasn't readily known that this is the case, but is to do the genetic studies to rule out microsatellite instability beforehand.
Did he have any kind of prevention for his obstructive symptoms besides the
No.
catheter?
No.
No,
He had a
no.
catheter. Well, a
Surgery.
massive, a 900 cc prostate attempting to do a TURP to open that up, I think would be problematic with bleeding and so forth.
Incontinence also.
Yeah. So, I mean, I was okay with radiating him. I think that at the time I didn't know about the possibility of microsat. This is, again, before some of this genetic information was widely known. But in retrospect, had I known, I would have managed him somewhat differently.
Great. Any
Yes,
other
ma'am.
question?
The experience I have as a urologist is having patient having urinary retention just after beginning the radiotherapy, and they are referred to me for doing TURP for this patient. Do you think that we can keep the stand and continue radiotherapy?
I would not recommend doing a TURP if a patient is getting radiation during the radiation, because the risk of complications, strictures, and all those things. I mean, so part of the take-home message is, so when patients have obstruction, they usually have obstruction from one of two reasons. Either it's tumor, so if they have obstruction due to diffuse involvement of the prostate, it's better to manage that obstruction with the radiation and the hormone therapy. Some people have baseline obstructive symptoms related to their normal urinary function. Those patients are not good candidates for radiation. So if you're going to do a TURP in those patients, that's different. But if it's diffuse, if the obstruction is caused by tumor, it's better to just treat the tumor, even if you have to have an indwelling Foley during the radiation, or if you use a suprapubic catheter, but not during the treatment, because the complication rate is much greater if you do that. And there was one young lady here that had a question.
It was about microsatellite instability. So do you look for MSI in patients even in high-risk prostate cancer? You don't wait to the patient that is metastatic disease?
Now we do panel, we screen, we do all kinds of genetic testing, something called UCSF 500. We look for all kinds of potential mutations. In those days, we did not, but nowadays, it's pretty much our standard practice. And I'm sure Maha has something to add.
I would say, though, each one of us have our anecdotal experiences, and there is the totality of the data. So to me, in a situation like this, if the patient has bulky local disease, then ADT plus an AR pathway inhibitor would be a great start. And I've seen clunky prostates that shrink over, let's say, 2 to 3 months of time treatment. And then implement radiation therapy, and then, of course, adjuvant hormone treatment. I have to say, though, Mac, in the metastatic setting, it's fascinating that MSI high, every time I test patients like NGS, it's a very small number of patients in my experience. Of course, statistics are different. And the concern one has is there's no guarantee, even when you're treating, let's say, bladder cancer, and patients had, potential targets for immune treatment. And it's not like everybody would respond. And this is really where you'd have to be, balance risks and benefits.
My
So I'm
patient-
not trying to be the
my
devil's
patient- no,
advocate
no, no.
here, but just to
My
highlight the
patients-
other side.
Yeah, the few patients that have had high MSI, in my experience, have responded very well with radiation. So I think they're also inherently more sensitive to radiation. Okay.
But are there any planned trials with RTOG, for example,
Well, the
for local
numbers are
regional
so
disease?
small, like you said, you're looking at 1%, 1.5%, maximum 2% of the patients. But I think that unusual patients, I think the percentage is higher. I think they present differently, but I've seen remarkable results in patients that have been treated with hormones and radiation.
If you permit a question also for my friend Moudouni, concerning the active surveillance, because you give us many contradictory information. Would you tell us, is it safe today in 2026 for low risk and for intermediate risk favorable? Is it safe to do active surveillance? Just to...
Je vais répondre en français, peut-être ça va intéresser tout le monde. Is it safe? Yes, I will say it's safe. It's safe to do active surveillance, especially in low-risk prostate cancer. Well, the definition of low-risk prostate cancer either in NCAS, EAU, and AUA have some limitation. The example Dr. Quash gave us is about sampling the biopsy, the prostate biopsy, target the visible lesion, the right lesion. This is where the science goes. I think that if we can overcome these difficulties to sample the good patient, to have the right patient, I think that it is a great option for, especially for young men, to overcome the downstream of the treatment.
Can we say that it's a warning to come from GG1 to GG2? Because GG2 can be on active surveillance, but when you have a patient, GG1, who is becoming GG2 after a while, can we stay on
I show you the
surveillance?
I show you the data that delaying surgery after upgrading to GG2, even 1 year later, doesn't worsen the prognosis. You don't have, for sure, extra prostatic invasion, or you don't worsen the prognosis of the patient.
So my urologists agree with you completely,
Okay,
but I don't. I don't do active surveillance in anybody with a grade group 2. If they have a Gleason 7, if they and the urologist want to be followed, that's fine. But if they're otherwise healthy and young, as soon as they have Gleason 7, I think that our ability, there's an interesting paper, there's a couple of interesting papers, and can we pick the 7s that need to have active surveillance or not? And I'm not comfortable with the data. I don't think, and the conclusion of the authors that, I think Loeb, L-O-E-B, she wrote a paper that suggested that they couldn't really do a good job at predicting which patients should be surveyed. And I love a paper from the Mayo Clinic. 1,688 men all had Gleason 7s. And if they looked at people that had Gleason 3 plus 4s, their 10-year biochemical control rate with a radical prostatectomy was 48%. So you have a young patient that has Gleason 7, and you're going to say, well, I'm going to follow you. I say, look at the cure rate in Gleason 7s, and if that cure rate is not that great, then I don't want to follow you. So I don't recommend active surveillance.
You think that Matt Cooper will agree with you?
No.
Okay, thank you.
That's what I said. You quoted all those papers, and they do follow some of them. But if the patient sees me, I'm saying, well, if you want to be followed, you be followed with him, okay?
Yeah.
These are the data. Gleason 7s are not that easy to cure. You're very curable now. I'm not convinced you're going to be as curable in 5 years.
Yeah, but I agree. I have a cancer with the Gleason pattern 4. I don't think we don't have this unanimity between pathologists to to give us the amount of Gleason pattern 4. And especially in neurologists, I was talking with the Professor Kuchelim about this. I think that this is the only specialty where Gleason pattern 4 is given in percentage. The other cancer is in centimeter, I think.
Yeah.
And this maybe this will change with AI.
You're right. I have a research project with a student. We're going through and pulling, because some people say we shouldn't be talking about percentage.
Yeah.
Because if it's a small piece, it could be 100% pattern 4.
Yeah.
If it's a long piece, you know, it could be 50% pattern 4, but it could be many millimeters of pattern 4.
Yeah.
So I'm not a pathologist, but I don't believe in doing active surveillance for Gleason 7s.
Mr. Mark Roach,
Professor Medoni?
in the real world,
Just
you know, in the real world, in United States, is there any equity concerning active surveillance? I mean, is it the same?
It's very safe.
Because there is a financial burden for the active surveillance. Maybe patients will choose to be treated rather than doing biopsy, MRI, genomic, I don't know.
I'm on the NCCN guideline committee. We write guidelines. The recommendations are active surveillance for low-risk patients, period. And I agree with it completely.
Professor Medoni, I have a question, please. You have detailed many diagnosis tools, and you have shown the role and the place of these tools for the inclusion and follow-up of active surveillance. My question is, don't you think that the combination of all these elements can enhance our approach for inclusion and for follow-up, as nomograms do?
Well, like Professor said, it will be a big burden for the patient and for the institution to add up the results of all this stuff to come together. I think that MRI is not available everywhere.
It's also not that good, and neither is PET.
Yeah.
Neither of them are good enough to really depend on. So
yeah. So I think, par contre, I think that micro ultrasonography will change a little bit the burden of active surveillance, because it's available everywhere. You don't have this waiting list to go to do MRI, and I think that the urologist will rely on what he's saying in ultrasonography, and he can also do a biopsy in the same time. Yeah.
Another question for active surveillance. Active surveillance is a gold standard of care for low-risk localized prostate, but it has limited. It can cause excessive anxiety. 20 and 30 patients go out protocol. It requires systematic biopsy. What are you think about the role of local therapy in treating the index lesion? Does it help reduce progression and the retard need treatment radical? What do you think?
We are talking about focal therapy.
In this situation.
For treating index tumor. Well, concerning the quality of life, I think that there is a paper who compare. This is a paper in 2024, I think, published in European Urology, comparing the quality of life of active surveillance, prostatectomy, radiation. I think that the conclusion was very clear that a patient who are on active surveillance have best quality of life in every item we choose.
Yeah.
The last question will be mine for Professor Roach. For local recurrences after radiation therapy, you prefer stereotactic radiation therapy over HDR brachytherapy or over prostatic radiation? Why do you
so
prefer
the question
SBRT?
is about how do we manage local recurrences after
why
radiation?
do you prefer
How do I
SBRT?
prefer? Well, there's a large systematic review and meta-analysis of the literature of surgery, cryo, HIFU, HDR, all the different, and prostatectomy. Yeah. And I think the morbidity of radiation salvage is lower than the morbidity of prostatectomy. And it's about patient selection. Not all patients are candidate for salvage radiation. The ideal patient for reirradiation is a patient who has a focal local recurrence. So typically, if you have a patient that has a lesion in their right lobe and you give them radiation and years later the PSA starts to go up and they have a recurrence in their right lobe, we just radiate the right lobe. And you can do that safely and carefully. If they have diffuse disease and they recur with diffuse disease, they're probably not a good candidate for salvage radiation. And so there are but for tolerability, convenience, we give 4 or 5 treatments in a patient that has a focal recurrence and morbidity is low. Very effective treatment. You can also do it with brachytherapy. So it really depends on what you're comfortable with. I've done brachytherapy on previously radiated patients. When I was young, we were told, don't radiate after radiation. Well, that's a myth. You can safely radiate after radiation, but patient selection and technique are very important.
In these cases, all decisions are outside guidelines and randomized controlled trial.
Well, we do have a prospective.
Do you have a board or?
We have a trial. It was only a phase 1-2 trial to look at the feasibility. Juanita Crook was the principal investigator. We showed that it's tolerated, that it's effective, and it's a good option. So we did a prospective study, and there's probably 10,000 patients in the systematic review that was done. They had like 10,000 patients. They had like 50 studies that looked at salvage prostatectomy. And so there's a whole body of literature on reirradiation, and we routinely do it. And it is in the NCCN guidelines of treatment for people with local recurrence.
When you have a case not in a guideline, outside guideline, how do you decide about the dose of radiation therapy, the dose of Zika boost, the sequence of systemic treatment?
Well, we can talk about it offline. I know that there's other people that need to speak, but I can go into it in great detail. The bottom line is when we reirradiate, we reconstruct the previous radiation in a computer. We design our planned new radiation in a computer. We then create a composite plan to make sure that the normal structures, such as the urethra and the rectum and the bladder, are respected. And generally, it's very well tolerated.
Thank you very much.
Okay.
Thank you very much.
Thank you.